I hope that all of you had a chance to explore and try out the live science demonstrations and meet some of our trainees. You can see them wearing the Late Late Lab t-shirts. At the Charbonneau Cancer Institute, our graduate students, these trainees, and our postdoctoral fellows play an important role in enabling our research. They are a highly talented group of individuals who are really working towards their careers in research and in medicine. I'd like to thank the Charbonneau Trainee Association for helping us host this event and run the live science demonstrations. I don't know where everybody is. Oh, right in front of me. I have very special thanks to Myra Chen, who's sitting right. Myra, you can wave to everybody. You got to turn around and wave. Myra Chen, Dan Berger, sitting right next to her, and Danielle Bozek, who is right in the middle there, for their help with planning and facilitating this event. I'd also like to acknowledge our Institute Director, Dr. Greg Cairncross. Greg, you're supposed to stand up or something. Okay, Greg Cairncross, woo, yeah. Who works tirelessly to advance the cancer research mission here in Calgary. And also our staff, especially our communications and events coordinator, Carmen Coelho, who is there. Yes, Carmen Coelho. So tonight, you're going to learn about some of the exciting cancer research that we are undertaking at the Charbonneau Institute with respect to cancer in young people. This lecture is going to feature three speakers. They're going to be three Charbonneau scientists whose work focuses on childhood cancer or young adult cancer. We chose to focus this talk on this topic because we often think of cancer as a disease of older adults. But as you'll learn tonight, hopefully, cancer can affect young people in different and often long-lasting ways that are different than adults. And we wanted to talk about those differences a little bit more. We're trying to address these differences in our research in a variety of domains: a psychosocial domain, a basic science domain. And so you're going to hear a diverse slate of speakers. We got Dr. Miranda Fidler-Benudia, Dr. Michael Monument, and Dr. Fiona Schulte, who will be our guest speakers for tonight. After these talks, so I'm going to give you a little bit of an intro, and then we'll go into the three talks. There will be an opportunity for questions afterwards at the end of the three, and we'll have like roving microphones for you to ask your questions. I just wanted to note that tonight's forum is not really the right place for dispensing individual medical advice, and for that you should seek counsel from your physicians, but happy to answer general questions in this area. After the question and answer period has finished, we're going to open up these scientific displays again, and also have the cash bars open, so that'll be available. So thank you for joining us tonight, and we hope you enjoy the session. So I guess the first question is, why are we talking about cancer in young people? Again, I thought, well, everybody thinks that cancer is a disease of predominantly older adults. But if you look at populations, it actually turns out that cancer is the leading disease-related cause of death in kids and adolescents, right? It's only after accidents as a cause of death in kids and adolescents. The good news is, even though it's a common cause of mortality among young people, the survival rates when you're diagnosed with cancer are consistently going up. So if we compare, 5-year survival from the 1960s to today, really it went from 1 in 5 kids surviving their childhood cancer to 4 in 5. That's a big change, right? So that's scientific progress. But I guess I'd like to point out a couple things with this, 83%, 4 in 5 survive, and that number, it hides a lot of different aspects of childhood cancer. One, obviously, is that, well, if 4 in 5 survive, well, 1 in 5 is not surviving. And if you delve a little bit deeper into what that 1 in 5 is, you'll see that there are certain types of cancer that are common in kids where we have not made progress as a field for decades. One of those areas is sarcomas, and later on tonight you're going to hear about some of the research we're doing in the sarcoma domain. The other thing that this says is that over time, as more and more kids survive, there are more and more issues that we have learned about survivorship after childhood cancer. And so you're also going to be hearing about some of the psychosocial challenges of childhood cancer survivors. And then lastly, I guess in all of this, who gets the cancer? You know, what types of cancer? And that also is not really reflected in this number here, but there are changes in the types of cancer that young people are getting. So the other speaker, Miranda, is going to talk to you about who gets it, what are the trends in young people's cancer. Okay, so I wanted to introduce you to a phrase that we often say in medicine, and that's kids are not just little adults. And when I say kids, I also include teenagers. Again, you can recognize them by their iPads or phones that they're always on. So these guys are not the same as these guys. I'll just have to say, I'm a little adult, right? I can walk into my 12 or 13-year-old class, my daughter's classrooms, and I'm the same size as everybody else. But the types of cancers that my kids would be at risk of getting are much different than the kinds of cancers that I would be at risk of getting. So I guess this goes back to many things that we talked about before, but I'll just quickly review with you the molecular basis of cancer. So I talked about some of the differences. Kids are part of families, and we're going to talk about some of the psychosocial challenges. But even on a molecular level, there are differences in childhood cancers and young adult cancers than adult cancers. So if we think about cancer as a disease of the DNA and a disease of the proliferation of cells, we can kind of think about cells being this thing over here, and all the DNA being sort of encoded in a library of books that has all the instructions for dictating how a cell should behave, what kind of cell should it become. And when we talk about cancer, we talk about alterations in the DNA, mutations, errors in the DNA that cause errors in the instructions such that this type of cell that should be sort of behaving well becomes this kind of cell that proliferates out of control. So with respect to sort of cancer across the ages, you can also see differences in the DNA and the types of diseases that kids and young adults get. So on one level, there are just fundamental differences in the types of cancer. So again, I won't go through exhaustive in detail, but the cancers that kids are at risk of getting are different than those that adults get. But furthermore, let's say, okay, in kids, brain cancer is very common. In adults, it's not very common, but it happens. Even if you were to look at that same type of cancer, let's say malignant glioma, glioblastoma, which is what I work on in the lab, even if you were to look under the microscope, they look the same. Cells kind of look the same. They kind of do the same thing. But if you look deeper, you'll see that there are some big differences in the molecular basis of those types of cancers, even if they look the same. So what do I mean by this? Well, one difference is that in general, kids' cancers are genetically a little bit simpler than adult cancers. The burden of mutations tends to be less than in older adult cancers. So that's I kind of show that here with the little asterisks. But the other thing is the types of alterations are also tend to be a little bit different. So, I said, okay, there's a book, and the books have instructions. So imagine if you started reading the book Moby Dick, and then you ended up, halfway through, the pages were spliced to a different book called Catcher in the Rye. That would cause some big errors. You wouldn't sort of have the right story. So those types of alterations, these things that we call translocations, tend to be a little bit more common in kids too, where you get one thing spliced onto another thing. So all of these things are differences between the type of cancers that kids get, young adults get, and older adults get. And so I just want to set the stage for you that there are some of these big differences. And without further ado, we're going to explore some of those at various levels with our guest speakers. So the first speaker is Dr. Miranda Fidler-Benudia. She's an adjunct assistant professor at the University of Calgary and a scientist with the Cancer Epidemiology and Prevention Research Group with Alberta Health Services.
All right, so thank you for having me here tonight to talk about something I'm so passionate about. So the name of my presentation is Small Numbers, Big Impact, and I hope by the end of this talk that you'll be able to understand why I chose this title. So as Jen alluded to, cancer is generally a disease of aging, and as a result, the number of cancer cases and deaths disproportionately affect older adults. So as you can see from this slide, 88% of new cancer diagnoses and 95% of cancer deaths occurred among Canadians over the age of 50 years. So you're probably wondering, why are we having this event tonight that focuses in on young people? So if so few cancer cases are occurring. Well, when you look worldwide, it actually isn't that few of numbers. So in 2018, there was an estimated 1.4 million people diagnosed with cancer before the age of 40. And when we zoom in and specifically look at North America, or specifically Canada, we can see that equates to approximately 10,500 cases per year in Canada, or around 29 diagnoses a day. And so if something's really that rare, I actually find that to be quite a big number. And when we compare this to other countries, we actually see that Canada has the 9th highest burden of cancer in young people in the world. When we break these numbers down into children, which are defined as 0 to 14-year-olds, and adolescent and young adults, or AYAs, which are defined as 15 to 39-year-olds, we can see that there are just over 1,000 cancer cases in children each year, and around 9,500 cases in adolescent and young adults. So today we really want to be talking about these people like shown here on the slide, some people in this room tonight who face cancer at a young age, and we need to be thinking about how can we help these people and what more can we be doing. So before I dive into this a bit more, I want to describe to you what cancer cases or what types of cancers are occurring in young people. So if we look on the left-hand slide here, this is 0 to 14-year-olds or children. And as you can see, the most common cancer cases or cancer types occur in our leukemia, central nervous system tumors or brain cancer, lymphoma, and neuroblastoma. When we then go up to the next group, the 15 to 29-year-olds, you can see that the cancer profile has already dramatically changed. So the top cancers that were occurring in children are no longer seen in 15 to 29-year-olds. Instead, we see thyroid and testicular cancer, Hodgkin lymphoma and non-Hodgkin lymphoma, melanoma, and bone and soft tissue sarcomas, which you'll hear more about in the next talk by Dr. Monument. When we then go to the upper age band of the adolescent and young adult group, so individuals in their 30s, we do still see some of these cancers that were occurring in 15 to 29-year-olds. So we do still see the thyroid and testicular cancers and melanoma, but we also start to see the cancers that we more commonly associate with cancer in the general population, that being specifically breast and colorectal cancer. And you can see in the 40-plus age group that these two cancers are here, along with lung and prostate cancer. So the take-home from this slide really is to say cancer in young people is very different from the cancers that we see in older adults. And even within young people, the cancers that are occurring are different depending on the age that we are assessing. So now that you have an idea of how many cancer cases are occurring and what types of cancers are happening, I want to talk about trends. So in this slide here, we're going to focus on children. And the green bars relate to the number of cancer cases that occur each year. And the pink line is the rate of cancer cases per 100,000. So how many cases per 100,000 children. And what you can see, just looking very broadly, is that the green bars are going up with time. And the pink line is going up a bit as well. And when we look only at the period of 1997 to 2012, so a 15-year period, we can see that childhood cancer has increased by approximately 2% each year. And this also holds when we start to look at specific types of cancer. So when we look at leukemia, there's been an increase of approximately 1.7%. For brain and central nervous system tumors, it's increased by approximately 3%. And even cancers that are less common in children, such as bone sarcomas or non-Hodgkin lymphomas, we are still seeing increases here. Similarly, increases are being observed for adolescent and young adults. As you can see from this slide, when we assess the period of 1992 to 2013, we saw that the number of cancer cases increased by over 18% for 15 to 29-year-olds, and by approximately 12% for 30 to 39-year-olds. So here we're really seeing quite massive increases compared to what we see in older adults, which, because of preventative strategies and decreases in risk factors, like less people are smoking nowadays, cancer is actually decreasing in this older adult range. And here I just want to highlight some of the work that I'm leading on. So here, this is looking at cancer in Canada, and I'm presenting colon cancer, rectal and anal cancer, and testicular cancer. And again, we're looking at the percentage change, but this time by specific age groups. So here, 20 represents 20 to 24. There's then a point for 25 to 29, and so on. So what you can see here is that all the increases, all the area, the cancers and age groups where there are increases is in the younger people. And this really is in contrast to people over age 50, where the rates are either decreasing or remaining relatively stable over time. So again, this is really highlighting the unique things that are going on with cancer in young people, which contrasts to older adult cancers. So as I just talked about, cancer is increasing in terms of numbers. And when we combine that with the really good 5-year survival that we have for childhood or adolescent young adult cancer, which ranges from 82 to 86%, depending on the age group assessed, we see that we have a growing number of young cancer survivors in Canada. And importantly, when we look at just the past 5 years, how many people were diagnosed and how many survived, we have 40,000 young cancer survivors, just in the last 5 years alone. So imagine what that number would be if we have the total number. And unlike older adults with cancer, these individuals will go on to live 40 to 80 years beyond their cancer diagnosis. And thus, it's really important to understand the needs of this cancer survivor population because they're quite unique. And I say that they're unique, and that is because we know that cancer and its treatment causes late effects, or pretty much negative things that happen immediately during treatment, as well as many years after. And on this slide here, I've just listed some of the important issues that young people with cancer face. So they experience educational and work disruptions, they may have fertility problems, they may be at an increased risk of chronic health conditions and experience poor quality of life. And in the next 2 slides, I'm going to speak specifically about employment and income and infertility, but you'll hear more in the talk by Dr. Fiona Schulte about the psychosocial late effects as well. So as I said, I wanted to talk about first the example of employment and income. And I know this is a busy slide, so I'm going to walk you through it. So in each bubble, there are 2 percentages. The top percentage relates to the percentage of people who did not work in the past year. And the bottom percentage is the percentage of individuals who had an income less than $40,000 per year. The green bubbles are then relate to data from people who had cancer, and the blue bubbles are their peers. And what you can see from practically every one of these bubbles is that the proportion or the percentage of individuals who are not working or have a low income is greater among the individuals who had cancer. And what we also notice is that these differences with their peers increase as they age. And this is a term that we call financial toxicity, and it relates to the fact that having cancer interrupts schooling or work, and this has long-lasting effects as well. And the second example I want to talk about is fertility, and that's because certain chemotherapy drugs and radiation to the abdominopelvic region can cause reproductive issues later on. So while some provinces in Canada have programs to assist these individuals, in Alberta there's nothing in place to help cancer survivors getting fertility treatments. So as a result, women will be expected to pay $10,000 to $20,000 for fertility preservation before they have treatment, or the same cost approximately to undergo in vitro fertilization. And even though getting a specimen from a male cancer survivor is easier, they still have storage fees as well, which range from $600 to $800. And for me, this really raises the ethical question of whether a young person with cancer should have to make a decision between paying out these costs or having a family. And if you just look over to the right-hand side of this slide, this was a project done by the Canadian Partnership Against Cancer. And what they did was try to assess what the increase would be to fertility services if all adolescent and young adult cancer survivors were referred. And what you can see clearly here is the greatest increase is occurring in Alberta, which really does suggest that these individuals are not getting the care they need. So what can we do? Now you have an idea of the landscape, you understand very briefly some of the issues going on. Let's think about what I can do, what you can do, and what we can do at the Charbonneau Cancer Institute. So first, we need to educate ourselves, because there is this misconception that cancer doesn't occur in young people. So on this slide, I just provided some of the symptoms for childhood cancer, but importantly, we need to educate not only individuals, but also health professionals, because most medical doctors will maybe see one young person with cancer in their career, if that. And as a result, we know that young people with cancer experience delays in getting diagnosed. So we need to increase awareness about the fact that cancer does occur, and if you see symptoms that look a bit strange, to go to your general practitioner. We also have to understand whether there are personal barriers that stop young people from getting diagnosed. You know, is it competing demands with family, friends, school, work, and so on? And if so, how do we try to limit these barriers in the future? The other way we can educate ourselves is knowing what is available to pick up on cancers early on. So for females in the audience, there is cervical cancer screening, and if you are of the recommended age, I highly suggest that you get screened for cervical cancer. But we can also have self-awareness, and that means using self-examination to look for lumps and bumps or to check for irregular moles. And like this, we could potentially pick up early on breast cancers, testicular cancers, and melanoma. Finally, there's not a clear definition of whether people who have increased risks of cancer in their family, whether they should be getting screened early on. And thus more work is to understand whether some young people should be getting screened at earlier ages. In terms of prevention, unlike older adult cancers, most childhood and AYA cancers are not strongly influenced by the major risk factors like smoking. That said, we can still prevent a substantial proportion of these cancers. So for example, vaccination against the human papillomavirus, or HPV, can substantially reduce the likelihood of developing cervical cancer later on. We can also have educational programs to really highlight the importance of protecting yourself against the sun. And you can see a really nice schema here from Australia that shows 5 different ways to protect against skin cancer. Finally, we can promote physical activity and healthy diets. We know that there's quite a lot of cancers that are related to excess body weight, so by promoting this, we can decrease those risks as well. And the great thing with all of these prevention strategies is that they will not only decrease the likelihood of having cancer as a young person, but also having cancer later on as well. And finally, research. We can do lots of research. So here I've just made 3 different areas related to the research that I'm doing and what I think needs to be done in the future for young people with cancer. So as I said at the beginning of this talk, we know that cancers are increasing in this young population, but we don't understand why. So we need to investigate the causes of these young cancers. And some of the work that we're interested in is to look at previous exposures to sexually transmitted infections and to see whether there's maybe a relationship there with some anal cancers. We also want to look at the microbiome, which is the bacteria in our body, or the bugs, and to see whether there's an imbalance there that could be leading to the development of early onset colorectal cancer. Second, as I said, we need to understand the impact and need, because this is a very unique group of cancer survivors. One initiative that we're undertaking is that we're taking advantage of the great use of electronic health records in our province. Everything is able to be linked together. And by linking cancer cases from the cancer registry to these electronic health records, we are able to anonymously obtain information on late effects, such as second cancers or hospitalizations. And the important thing we can also do here is health services research. So trying to understand how often these cancer survivors are using the healthcare system, and whether we need to institute some kind of assistance for them that would help them with their health problems. And finally, develop interventions. As I talked about, late effects are a real issue, and whilst we maybe can't intervene to prevent all of these cancers, we definitely can intervene to stop or lessen the degree of late effects. And I'm going to take you through one of the examples we're currently developing in my department. So this is called AYA PACT, or the Adolescents and Young Adults Becoming Physically Active After Cancer Trial. And what this trial is looking at is, right now, hopefully, young people with cancer are at least getting educational materials about how to be physically active after treatment. What we want to do is to combine those educational materials with a personalized physical activity prescription or plan, as well as an activity tracker watch, and an online community of other adolescent and young adult cancer survivors. And really, this trial is building on the tech savviness of young people, and we're hoping by linking them all together, we will be able to improve outcomes. And we will do that because having the activity tracker watch allows the individual to look at their physical activity in real time. They can assess the steps they take, their heart rate, how much they slept, how much they sat, and so on. So they can use this information, which provides information to them. They can also share it on the online community to provide support to one another. And we can also use it because we can see whether or not they're achieving the goal that is recommended right now. So you can see we can use text messaging to then say, hey, great job for meeting your physical activity goal this week. Keep up the good work. Another example is to use text messaging when we know that there's issues. And this example here, I'm not sure if you can read it, but it relates to the cold, a problem that anyone trying to do physical activity in Calgary will face. And here, rather than just accepting that they're not going to be physically active, we're suggesting, hey, wear layers and try fun activities like snowshoeing or ice skating. So we're just trying to keep suggesting and motivating them despite what could be barriers. And the final thing we have in this study, which is quite unique, is what we call ecological momentary assessments. And basically all that is speaking with our participants to understand how the trial is working for them. So in this text message here, we're asking them, what are the barriers to being physically active that week? Text 1 for energy or motivation, text 2 for time, text 3 for health or injury, and text 4 for no barriers. And this is really a great way to not only improve our study by listening to actual participants, but it also engages them and it keeps them active and willing, and they're part of the research themselves. And really, the goal of this study is to improve physical health. Obviously, we want to improve endurance, get their strength back, maybe change their body composition if they put on some weight. We also want to look at psychosocial outcomes like quality of life or hopefully decrease distress, because physical activity is one of those great things that can affect so many things in our lives. And finally, in a more clinical sense, we want to look at fasting blood samples, because as I said, we know chronic health conditions are a problem in this population. So if we see that this trial decreases markers for diabetes or cardiovascular disease, we can put this at the larger scale and really start preventing some of these late effects that occur due to treatment. So that is the end of my talk. I thank you for listening, and I hope by now you understand that despite the fact that cancer is less common in this population, there is a very huge impact. And now you'll hear from Dr. Mike Monument, who is an orthopedic surgeon within the Charbonneau Cancer Institute. Thank you.
Okay, well, welcome. Good evening. It's exciting to see everyone here, and I'm certainly excited to share some of the cool and interesting work we're doing both in the clinic and in surgery, but as well in some of our research laboratories. As you heard, I'm an orthopedic surgeon, so I'm a bone and joint surgeon, but my focus is actually bone and joint cancers in both pediatric patients and as well adults. And I also have a research program in the lab where we're actually trying to study bone and soft tissue sarcomas in particular to try and look for some new therapeutic options for our patients. A couple disclosure statements. So I am a surgeon, so you will see a few intraoperative OR images, maybe a couple tumor specimens, and as well, we have a few animal research images, so I thought I'd just give you the heads up. A few of these images are coming. I have no financial disclosures related to this talk. So what is a sarcoma? I imagine a lot of people have never heard of a sarcoma until coming to this seminar tonight. But sarcomas are cancers that essentially arise from connective tissues in the body. So connective tissues like bone, muscle, fat, skin, even some of the tissues around tendons and ligaments around the joint. Now, sarcomas are rare. They actually account for about less than 1% of all cancers, but they disproportionately affect children and young adults and represent about 15 to 20% of solid cancers in pediatric patients and as well adolescents and young adults. So there's two broad categories of sarcoma. The first category are bone sarcomas. So bone sarcomas are malignancies that originate within the stem cells within the bone or within the bone progenitor cells. Usually occur in patients 10 to 30 years of age. Most common in the long bones. So these are the bones that are actively growing, metabolically changing over time, especially during periods of growth. And the femur, being the biggest bone in the body and the most actively growing body, is one of the most common sites for bone sarcomas. We also see sarcomas in the pelvis and the spine, which have their own challenges from an anatomic standpoint. And these patients present with vague pain. So they'll have knee pain or a bit of dull, achy thigh pain. And it may be 6 to 8 months from when they first present with pain to when they actually get a tissue diagnosis. Here's a picture just showing you here. This is a bone sarcoma. So this is the femur bone, and you can see this cloudy mass that seems to be bursting out of the bone, and that's a classic osteosarcoma. Soft tissue sarcomas, on the other hand, can affect patients of all age categories, so anywhere from young children less than a year of age to patients in their 80s and their 90s, although the vast majority of soft tissue sarcomas still present in adolescents and young adults. And these form outside of the bone, so in the muscle or in the fat. They can occur essentially anywhere, but are most common in the extremities. And they don't hurt. They just present as a painless mass. So again, you'll notice a patient will notice a slight size difference in one limb to the other, but it doesn't hurt, and they carry on, and again, 6 to 8 months before a diagnosis can be reached. Here's a soft tissue sarcoma that is growing in this man's hand, and it's actually almost penetrating through the skin. Here's a few more images of some bone sarcomas. So here is another picture of this is the femur bone. Here's the knee joint, and here's this big tumor. You can see the cloud of new bone that's exploding out of the bone. This is in about a 17-year-old patient. And this is a younger patient, about 9 years old. You can see the open growth plate up here near the hip joint. And you can see this bone sarcoma just increasing in size, changing the architecture and the structure of the bone, weakening the bone. This patient would be limping and walking with pain. So osteosarcoma is the most common bone sarcoma, and most Canadians know Terry Fox. Terry Fox, this was the cancer that Terry Fox was diagnosed with. This was back in the late 70s, and his surgical treatment was a pretty radical surgery in the form of an above-knee amputation. So for those that didn't know, that's cancer that Terry Fox was diagnosed with, and so certainly he's an important Canadian that represents some of the struggles in the domain of sarcoma. You can see here some images of a soft tissue sarcoma. So this is a cross-sectional image of someone's thigh. So this black tubular structure is the femur bone, and you can see this big, bright mass that's growing inside the quadriceps muscle. That's an aggressive, fast-growing sarcoma. This is what it looks like when we remove it surgically, and it's quite big. It's bigger than our instruments. And this is a 4-month-old child that had a soft tissue sarcoma in the palm of their hand that we had to remove. So it just goes to show you the breadth of patients that can be involved by soft tissue sarcomas. So how do we treat sarcomas? Well, the management of sarcomas is very intense. It's very multidisciplinary. We require expertise from a variety of different fields within medicine. So whether it's medical or pediatric oncologists that would administer chemotherapy for bone sarcoma patients, radiation oncologists, surgeons, intensive nursing, physiotherapy and rehabilitation, as well as psychosocial support. As a surgeon, my job is to perform like a curative intent resection of this sarcoma. So my job is to cut this thing out and leave nothing behind. And you can see in my little animation here is the tumor in red, and the surgical approach, which really hasn't changed in years, is to remove the entire tumor with a cuff of normal tissue around it. So essentially we don't leave any microscopic cells behind. And historically, for a lot of our sarcoma surgeries, again, going back to this big osteosarcoma in the femur bone, surgery would have been an amputation, very similar to what Terry Fox had. We've had advances in our diagnostic imaging, so our MRIs are much more sensitive. They can pick up the precise anatomic details of where the tumor is. We also have surgical techniques, reconstruction efforts of muscle and bone, and we actually incorporate plastic surgery and other disciplines now, so we can do a lot more. We can salvage the limb in a vast majority of these cases. So here's an example of an osteosarcoma, and you can see the gray outline there is the negative margin resection that is required to be curative with our surgery. So we're removing essentially the lower third of the entire femur bone and as well the entire knee joint. And so intraoperatively, if you look at the top panel here, this is the resection. So the bone cut is here. This is all of the muscle in front and behind the knee. And then you can see in the lower panel, we've now reconstructed the deficit with a large metallic prosthesis. And this is the end of the femur bone now. This is the knee joint. You can see the undersurface of the kneecap here. And then this is what the x-ray would look like. So there is the entire finished product on an x-ray, and it looks very elaborate, but the end result is this patient would actually function very similar to, say, a 70-year-old patient that has their knee replaced for arthritis. Here's another example. This is a bone sarcoma that occupies a large proportion of the femur. So you see on this view, here's the bone sarcoma here. You can see the bone sarcoma in the side view. The surgical resection involves removing, about 75% of the bone. And we're able to use actually bone from the bone bank or cadaveric bone to reconstitute that defect, and we use some fancy plates and screws to lock everything down, and the patient can start walking on this probably in about 6 to 8 weeks. Soft tissue sarcomas are a little bit less complicated from a resection standpoint. They don't involve the bone. They can still be quite large and deep. So in this case, you can see this is the size of the sarcoma at the end resection. And you can see we have to remove a pretty significant amount of skin and all the muscle associated with this. Sometimes we luck out and the soft tissue sarcomas are superficial. And what I mean by that is they're above the muscle or they're just in the skin. So this is a resection. You can see the quadricep muscle here, and all we've had to do is resect the skin and the subcutaneous fat. So a lot of these bone sarcomas occur in children, and they occur in children that are still growing. So we actually have a few technologic advancements to try and help us accommodate the growing child. And so here in this image here, you can see the replacement that we've done here for this end of the femur bone that's been replaced with a prosthesis. And we can actually use a prosthesis that over time we can get it to expand millimeter by millimeter so that we can try and give this leg a chance to grow over time. Sometimes we have to shut down the growth plates, as you see here on the other leg. So this is the growth plate in red, and these little metallic plates and screws just kind of squeeze the growth plate so it doesn't grow quite as fast. And that way, when the child's done growing, their legs are actually symmetrical in their length. Here's an example. It's a little bit more extreme. So this is a 9-year-old patient, 9-year-old male, has lots of growing left. It's going to be very challenging to resect this entire tumor and give a leg that's going to match the length of the other leg over time. So we do something a little bit more intense in this case where we actually resect the entire femur bone, we resect the entire knee joint and even some of the shin bone, and then we reattach the shin bone to what's left of the femur bone, and at the same time we rotate the leg around about 180 degrees, and you can see what it looks like here. So now The ankle joint is actually functioning like the knee joint. Now this looks crazy, and it is crazy, and it looks very abnormal, but now you have a prosthesis that this child can go into, and they can put their heel, it rests right in this part of the prosthesis, and they can function very similar to a patient with a good prosthetic below the knee amputation. So this guy's Tim's, one of my patients from years ago. You can't even tell when he's got pants on and he's walking that he has anything done. He can wakeboard, he can ski, he can play soccer. He's actually very functional with this. So I've painted a picture of some of the cool things that we do in surgery, some of the unique intraoperative technologies that we use, but I still want to stress that sarcoma is a very challenging diagnosis. These are large tumors. By the time we actually see them in surgery, they're very big, so it requires massive, morbid surgical resections that permanently change body image and body function. A lot of these surgeries or these sarcomas are treated, especially the bone sarcomas, are treated with toxic chemotherapy. They're aggressive, they're bad acting cancers. So these aren't the cancers that are now in that 85, 86% survival. The 5-year survival for a high-grade bone or soft tissue sarcoma is still 70% or less. A lot of them will metastasize, they'll spread to the lungs, and once this happens, once a sarcoma spreads from either the muscle, the fat, or the bone to the lung, they're essentially not curable, and we don't have drugs that can even slow them down once they spread. There really, and I think Jen mentioned it earlier, but there really hasn't been any new therapies for sarcomas in over 20 years. So we need to do something. We need to improve our arsenal of treatment for these patients. So here's a case of mine. This is a case that's still ongoing. This is a 25-year-old female, had a soft tissue sarcoma called synovial sarcoma, which is quite common in adolescents and young adults. This is the MRI showing her foot. So this is the bones of her foot right here, and you can see this soft tissue sarcoma kind of stuck between the bones there. Unfortunately, we had to do a below-the-knee amputation for her. That was the only way we could actually properly treat this. And she was great. She had a prosthesis on, very bubbly, energetic girl, was doing really well, and then came in for her 2-year follow-up. And we have an image of her chest here. There's a CT scan, and you can see she starts to develop these little nodules in the lung. So she now has recurrence of her sarcoma in the lungs, and the treatments, we just don't have any treatments that are going to be effective for her. And we had these very painful discussions in clinic. Do we try and look at a clinical trial in the United States or go somewhere else for her care? And again, it just goes to show the deficiencies in what care we have for our sarcoma patients. So there's a lot of priorities that I think are worth highlighting for what needs to be done in sarcoma research. In my personal opinion, I still think the biggest priority is to find some new drugs, some new therapies, some new treatments that we can treat either patients and shrink their tumors or give our patients some treatment that if they have metastatic disease, a treatment that actually works. Because these are rare conditions, we also need to up our game in how we procure, how we store samples of sarcomas from surgery so that we can do research down the road. We need better detection imaging, whether to detect cancers earlier, sarcomas earlier, or to detect them when they recur earlier. We also need better research on quality of life. As you saw from a lot of these images, we do very aggressive surgeries on these patients, and we really don't know how their quality of life is affected years and years down the road. And then near and dear to my heart, there's also a real strong pressing need to improve our development of animal models that we can use as research tools to understand the biology of sarcoma and how we can find new drugs for sarcoma. When I finished my orthopedic training in 2011, I went down to the United States for some additional sarcoma training and research. There really wasn't any sarcoma research going on in Calgary. And you fast forward now to 2019, and it's really impressive. We have this growing critical mass of clinicians and researchers that are all very invested into sarcoma research. And I'm a part of that team, and that team is growing, and it's really quite fantastic. And I show some of the investigators here, and it's not even showing all of the research the graduate students, the postdocs that are involved in this. And we're doing really exciting research, everything from new drug identification to immunotherapies to improvements in our biobanking and even some precision oncology and sequencing of these tumors. Some of the work that we've been doing in my lab is to make some animal models of sarcoma. Now, some people in the room might wonder, well, do you need to make, animal models or do animal research? Well, the reality is that sarcoma is rare. We don't have a lot of samples, a lot of patients every year. There might be maybe 10 to 12 bone sarcomas in a given year in Calgary. So it's really hard to study a rare disease without having a good animal model. Clinical trials are difficult to execute, and we just need better models to understand tumor immunology and develop new therapies. So what we do in my lab is we will engineer these mice using a viral injection either in the bone or the muscle, but we'll engineer these mice to have mutations in some of the common genes that we see mutated in sarcoma, and we can inject the virus and elicit the mutation, say, in the muscle, and we can get a muscle sarcoma in this mouse, or I can put an injection towards the growth plate in the bone, and we can get an osteosarcoma in this mouse. And so now that we have these models, we can use these models to try and understand, do they relate to the human condition? So we've done some fancy genetic sequencing on these tumors, and certainly the genetic mutations of the mouse sarcomas are similar to the human sarcomas, and we can even engineer them to sort of glow in the dark. So we can actually monitor them in the lab in real time in live animals to see, how they're growing in the leg or how they're spreading to the lungs in this case. So we've developed an adult soft tissue sarcoma mouse model, we've developed an osteosarcoma mouse model, and we've even developed a pediatric soft tissue sarcoma model. So we now have some models that we can work with as tools to further our research. So now that we have these models, what do we do with these models? And I'm certainly, I've been drinking the Kool-Aid. I'm very passionate that I think immunotherapy is going to be an exciting new approach for sarcoma patients. And immunotherapy has really taken off in a lot of different other cancer subtypes, whether it be melanoma or lung cancer or kidney cancer. And the central theme of immunotherapy is you're using the body's own immune system to identify, to seek out, to attack and destroy cancer cells. And in this animation here, you can see this is a T cell, a killer T cell in the immune system that's seeing a cancer cell, recognizing it, and destroying it. And these killer T cells are really one of the principal immune cell types that is active and we're trying to manipulate or activate in immunotherapies. Sarcoma immunotherapy so far hasn't been great. There's been a few clinical trials using the same immunotherapies that have been working in lung and melanoma, and they just haven't been working in sarcoma. And one of the reasons for this is sarcomas, they're just not like adult cancers. They don't have the same mutations, the same burden of mutations. We don't have the same population of immune cells within sarcomas that we'd see in lung cancer or melanoma. And so they're really resistant to some of these new trials that are working really well for adult cancers, and it's quite frustrating. Our models of these mouse models of sarcoma, we can actually show that when we look at the proportion of immune cells in the sarcomas, just like we're seeing in humans, they really don't have any of these killer T cells in the sarcoma. And in the world of sarcoma, or the world of tumor immunology, we would call these a cold tumor. So sarcomas are right here. So they're cold. They don't have immune cells. They're not inflamed. It's cancer cells and a few maybe suppressive immune cells, but there's really no hot inflammation, where this would be more like a lung cancer, like a melanoma. So lots of mutations. There's lots of immune cells within the tumor, and therefore very responsive to immunotherapies. So what we're trying to do in the lab with our mouse models is we're trying to take our sarcomas and turn them from a cold tumor into a hot tumor. And if we can do that, if we can turn it from cold into hot and bring immune cells in, make it inflamed, can we actually sensitize it to some of these immunotherapies? So this is a particular compound that we're interested in the lab. I noticed the graduate students in my lab actually blinged up their lab coats with the chemical structure of this. So this is an immune stimulant, and we can actually inject this small molecule right into the tumor, and it's a known vascular disrupting agent, so it'll actually cause lysis and disruption of the blood vessels, and it also awakens the immune system. It can actually recruit these killer T cells, which we're very interested in bringing into our sarcomas. So you can just see in this schematic, we grow a tumor up in our mouse, and once we can feel it, once it glows in the dark, we inject it with this stimulant, and we're trying to figure out now, does it make it a hot tumor? Does it inflame the tumor? So this was a first series of experiments that we did in the lab where we were just trying to test out to see if it works. So here's day 0, and you can see the bright signal here corresponds to this big growing sarcoma in the mouse's leg. And you see 10 days after we've injected this immune stimulant, you can see the signal is really going down. And now you fast forward to 2 months, and you can see the signal is almost gone in most of these mice. So we were actually pretty surprised at this. We weren't expecting the tumor to go down like this, but we're certainly happy. And you can see when we look at it under the microscope, you can see all of these immune cells, these lymphocytes, these killer T cells are now showing up on the scene. This is a survival plot, so we have days here on the horizontal axis, we have percent survival on the vertical axis, and you can see in our animals that were treated with this drug, almost up to 3 months here, we have about 60% survival, long-term survival in our mice, which was fantastic. We're really excited about that. We even went as far to look at some of these mice that were surviving, so we took this population that represents this part of the survival graph here, these mice that are still alive, and we said, what happens if we give them cancer again? We give them a recurrence of their sarcoma, and you can see here's the recurrence. So here's the leg that was cured, and now we've given them sarcoma in the other leg, and you see if we fast forward 3 weeks, they've rejected it, or it's now gone. Where if you look at control mice, these were mice that never received the drug. Here's day 0, and at day 21, the tumor continues to grow along. So we've almost demonstrated some sort of protective immunity, not just an ability to treat the primary cancer, but some immunity that protects against the subsequent recurrence. So there's lots to do, there's lots to flush out with this, there's a lot of mechanistic understanding, but we're really excited about this. So the next steps, there's about 50 different subtypes of sarcoma, so we're going to keep making different mouse models of sarcoma. We're going to keep trying this new strategy with various different subtypes of sarcoma. We're going to see if this type of therapy is actually synergistic with other immune therapies, whether it be oncolytic viruses or checkpoint inhibitors, or even synergistic with radiation therapy, for example. We're keen to see what these killer T cells are recognizing. Are they recognizing some sort of antigen or something sarcoma-specific that we can maybe expand upon and develop new therapies for? And then if the results continue to be validated with multiple experiments and different models, is it time to start thinking about drug selection, dosing parameters, thinking about a clinical trial? So in summary, sarcomas, they do account, unfortunately, about 15 to 20% of pediatric and young adult cancers. They're aggressive, they're bad, it's heavy-duty medicine and surgery to try and treat these cancers, and we really need new drugs. And I'm very optimistic that there's some new opportunities on the horizon. I think we're doing some pretty cool stuff at the Charbonneau, and we'll keep you posted on how things go. And I think at that, I'd like to thank a few different people that have helped out. So my lab members, a few of them are here today. They're the ones doing all the hard work and all of these figures and the data. So I'm very grateful to this strong team I have in the lab. Some of our funding sources, some of our Alberta, business partnerships, and as well, a lot of really smart people and mentors that I have in the lab that have been helping me out. And we'll move on now to Fiona Schulte's talk, and look forward to taking questions after.
Okay, good evening, everybody. My name is Fiona Schulte. I am an assistant professor in the Department of Oncology within the Division of Psychosocial Oncology at the University of Calgary. I'm also a clinical psychologist at the Alberta Children's Hospital. And my research is in the field of psychosocial oncology. I'm focusing specifically on the cancer experience of children, adolescents, and young adults. For those that don't know, psychosocial oncology has been defined as the emotional, psychological, social, spiritual, and functional aspects of the patient's and family's experience, as well as the interplay between behavior, physical health, and well-being. And lucky for me, and the reason I can be here today, psychosocial oncology is actually a relatively new field, particularly as it relates to cancer in young people. This is because it has only been in the last few decades that children have been surviving their disease. Childhood cancer is a medical success story. In the 1960s, as Dr. Chan had mentioned in her introductory talk, the survival rate for childhood cancer was only 28%. Thanks to emerging technologies and new treatments, by the 1970s, survival rates have started to improve. But in the 1980s, we started to see some of the long-term physical consequences of the toxic therapies that we were giving to children, including the development of secondary cancers and the development of heart problems. It wasn't until the 1990s that there emerged an acknowledgement that children actually feel as it relates to their cancer experience. So prior to this time, we didn't understand that children were actually understanding more about the seriousness of their diagnosis than we were giving them credit for. that they were experiencing pain in relation to the procedures that they were required to undergo, that they were feeling isolated when they were hospitalized, and that they indeed feared for their future. So in the 2000s, we've been able to move now to focus more on quality of life, especially in the context of clinical trials, and questions have emerged about whether the toxicities of treatment can be reduced in an effort to preserve quality of life. Presently, as has been highlighted, the survival rate for cancer in young people, which is generally understood as someone who's 2 years post-completion of their therapy, ranges from about 82 to 86% in Canada, which is amazing. So today, 4 out of 5 children will survive their disease, but we still have about 1,400 children who are diagnosed with cancer in Canada each year. About 80 of those are here in Calgary. And cancer remains the #1 leading cause of death by disease in children. But in Canada today, we have an estimated 30,000 survivors of childhood cancer, which is amazing. And our long-term survivor clinic at the Alberta Children's Hospital is currently following about 500 of these. As has been highlighted, cancer in young people is a unique disease. Biologically, we see different cancers among this age group, and also when we talk about cancer in young people, we must consider that the care of the child is really embedded within the family. Children are not just little adults. So we cannot extrapolate from what we know about adult cancers and attempt to apply this understanding to the young person. Separate, specific research in this field is needed. Perhaps the greatest difference about cancer in young people is that cancer strikes at a time of enormous development. Physically, we see major changes from babies through to adolescence. Social and emotional development also changes dramatically during this time, with early signs of interaction from babies to the development of friendships in school-aged children, and then a shift to gaining more independence in adolescence. And each of these processes is intimately linked to the child's cognitive and brain development. Cognitively, the brain develops at a phenomenal rate during childhood and adolescence, with data suggesting that the brain continues to develop until the age of 21 years. It is not surprising then that toxic therapies delivered to children to treat cancer at this extremely vulnerable stage can have devastating effects. So while we have impressive survival rates when it comes to cancer in young people, it does come at a cost. And research now must focus on carefully balancing the need for intense therapies to achieve cure with the potential for long-term complications that might compromise quality of life. Current research tells us that 75% of these young survivors will experience at least one late effect of their diagnosis or treatment. Late effects are health problems that occur months or years after completion of cancer therapy. Late effects may be caused by the cancer itself, or may be caused by the treatment that's required to cure the cancer, such as chemotherapy, radiation, or surgery. Late effects may be physical and can include heart damage, infertility, or the development of secondary cancers. And unfortunately, many survivors will experience multiple late effects over their lifetime. The burden of late effects can be significant. My lab has been conducting some research to try to capture the burden of some of these late effects by interviewing survivors and their caregivers. This is a quote from a young survivor that I believe captures some of this burden. She states, "It's like, well, I'm 20, but I feel like I'm 80. Pain-wise, I sometimes feel like a wimp. I feel like I'm an old person. My hips are like super weak, so even in the cold, if I'm walking, it's like I'm an 80-year-old, I'm limping, and it's horrible." Psychosocial late effects feature prominently among survivors of childhood cancer. These may be a late effect of the cancer itself, resulting from the treatment of cancer, may result from the trauma of being diagnosed with a life-threatening illness, or may be a consequence of the experience of other late effects. Psychosocial late effects in young people may include social withdrawal, cognitive problems, fatigue, issues with body image, depression, anxiety, post-traumatic stress, and unfortunately also suicidal ideation. What this translates to in adulthood means that generally survivors of childhood cancer are less likely than their siblings or their peers to complete the same levels of education, less likely to be employed, less likely to live independently, and less likely to be in intimate relationships. We do know that there are some survivors at greater risk of experiencing psychosocial difficulties than others. This may be related to family factors, such as financial hardship or a previous history of mental health within the family, may be related to factors within the child themselves, so the age at which they're diagnosed or whether they have a pre-existing history of learning or emotional difficulties, may be related to the diagnosis that they receive, and we know that young people who are diagnosed with a brain tumor, or as Dr. Monument had spoken about, sarcomas, are at greater risk of experiencing psychosocial difficulties. And finally, may be related to the treatment they receive, with those who receive treatment directed at the brain or those who undergo bone marrow transplant to be at greater risk. Survivors are not the only ones at risk of experiencing psychological difficulties following their cancer treatment. And as I mentioned earlier, when we talk about cancer in young people, the care of the young person is embedded within the family. When we look at parent functioning in childhood cancer, understandably, we see significant distress at the time of diagnosis and through active treatment. When we look at parents of survivors, we see, however, there persists a substantial subgroup who continue to report clinical levels of psychological distress, 21 to 44% who report severe post-traumatic stress symptoms, as well as worries and marital strains. I have another quote from a survivor that highlights the challenges for parents. And the survivor said, "Not too long ago, she would take me straight to the children's hospital as soon as anything would be wrong. Early survivorship was kind of seeing my mom worry all the time. So I remember I slept in her bed with her and my dad. I didn't have my own room. I would just sleep in their room 24/7 in their bed, and I would constantly be taken care of." And this is from a survivor many years after their therapy. As you can imagine, the experience is also extremely challenging for siblings. Practically, siblings often have to stay with other family members or friends when the sick child is hospitalized. They may feel sad about the loss of their playmate, or they may feel jealous about the extra attention that their brother or sister is receiving. Siblings of survivors report symptoms of post-traumatic stress, poorer academic functioning, risky health behaviors when they get older, including smoking and drinking, and poorer health outcomes. What is interesting is the interaction between survivors, siblings, and parents. So we conducted a study a couple of years ago looking at how survivors and siblings rated their own quality of life and compared this to how parents rated the survivor or siblings' quality of life. These survivors were an average of 10 years after completion of their therapy. And results of this study showed, not surprising, survivors reported a little bit lower quality of life than their siblings. But what was most interesting is the parent perception of their children's quality of life. When it came to survivors, parents reported their survivors' quality of life to be worse than that was perceived by the survivors themselves. Whereas with the siblings, parents reported the siblings' quality of life to be better than that perceived by the sibling. So what can we do? This is actually a really exciting time to be conducting research in this field. The numbers of survivors are growing exponentially, and knowledge related to the late effects of childhood cancer is a dynamic, continuously evolving field, given changing treatment protocols and the development of new knowledge as these young survivors age. Our lab at the University of Calgary, within the Charbonneau Cancer Research Institute, is conducting research to understand the psychosocial late effects of young people who have survived cancer in an attempt to improve the experience of these young survivors. Specifically, we are conducting studies that investigate the social development of children who have survived cancer. We are also interested in the quality of life of these young survivors and are leading studies that incorporate quality of life assessments into multi-site clinical trials. We think it is important to understand the burden of symptoms that these young people face and are conducting research focused on sleep difficulties, fatigue, and pain outcomes. And finally, we are interested in the mental health of these young cancer patients, including examinations of anxiety in the form of fear of cancer recurrence and post-traumatic stress. Ultimately, our goal within each of these areas of research is to identify ways to intervene and improve the lived experience for these young people. I wanted to take a few minutes to share one of the research projects we are working on. And there is existing evidence now that is documented that survivors of childhood brain tumor experience significant social difficulties. Unfortunately, however, we do not yet understand why these survivors have difficulties. We know that understanding the mechanisms behind their social difficulties is critical for us to be able to develop effective interventions. So we are currently recruiting survivors of childhood brain tumor from the Alberta Children's Hospital, and survivors and their caregivers are being invited to come to the hospital to complete a battery of questionnaires that assess their social function. At the same time, survivors are undergoing an MRI to help us see whether there may be structural changes to the brain that have been caused by the therapy they've received to treat the tumor that might be related to their social function. We are also going into the survivors' schools, and we're speaking to the peers and teachers about how these survivors function within the classroom. We are comparing these results to children who have not had a brain tumor or any chronic illness, and we think that by collecting all of these different measures of social function that we might be able to see where the difficulties lie, and this will ultimately help us to develop targeted interventions. If we can accomplish this for survivors of brain tumor, we may be able to apply the same model to understand difficulties by other survivors of cancer. The outcome of this type of research is to be able to identify those children who may be at risk and to develop interventions that may improve their lived experience. Ultimately, our goal is to try to improve the quality of life of these young survivors. I did want to leave this presentation and the presentations of this evening with a bit of a positive note. And I think while the experience for cancer in young people can be traumatic for the child, there is also really the potential for positive growth. One survivor shared, "If anything, it made me more grateful, and it made me kind of think of life as unfair, because I walk through the Children's Hospital once a year, and I see kids who are where I was, but maybe they won't get better. It's really sad, and it's just not a good feeling to have. I think that's why I want to pursue medicine. So in the long term, being a survivor definitely made me grateful. But if anything, it made me realize what I want to do and how I feel so bad for all the kids that suffered like I did, and I want to make their lives better." I think we want to make their lives better also. So I want to thank you. I'd like to thank the members of my lab, thank all the patients and families that I have had the privilege of working with over the years, and to thank the Charbonneau Cancer Research Institute for having me here to talk, and for all of you for being here this evening.